We had a consultative meeting to see, is that a priority, is that really a gap? And it turned out that they were already hungry or thirsty for such a thing, for a data system that allows them to look at the child holistically. And also they were also thirsty for something that will strengthen their multi-sectoral collaboration.
We want to track pregnant mothers throughout the pregnancy up to birth. Then after birth, what next? We want to track these children up to the milestone level of age 3. Because we believe between 0 to age 3, that is where we experience the maximum brain development of a child. And that caters for a lot. And that is why the 5 pillars that govern nurturing care at this stage are very important.
Every department has its own way of collecting data. And we collect data so that at least we can track performance. We are able to make decisions. We are able to just monitor progress. Yeah. But again, you realize that those siloed type of data collection tools, when now we come into the ECD space, this child belongs to everybody. Yeah. There are health indicators that we track. There's also education indicators that they track. There are the social indicators, issues to do with poverty, issues to do with the disabilities that are also tracked. The GIS team is also trying to map where, in terms of heat maps, and where do we have the classrooms and all that. So where I sit, I believe that what APHRC is bringing on board is an innovation. And this one speaks to the vision, actually, of this country. How can we bring innovations on the table that can help key decision makers put things together and make the right informed decision?
Tunapima weight ya mtoto, tunapima height ya mtoto, then clerks wako pale kwa meza, wataangalia mtoto anapata chanjo gani. Hii data yote tuko na kitabu ambao tunaandika hiyo data ikifika end month. So tunaangalia hii month yote, watoto wangapi walipata BCG, watoto wangapi walipata first polio, second polio, third, hizo first doses, second doses zote. Malaria pia tuko na malaria 1 at 6 months, tuko na malaria 2 at 7 months, malaria 3 at 9 months, then tuko na malaria 4 at 2 years. So tukishaangalia hiyo month yote, hizo chanjo zote, ni watoto wangapi ambao walipata hizo chanjo, then tunaandika hiyo ripoti. Hiyo ripoti tunaipeleka kwa mtu wetu wa data, then hiyo mtu wa data anaipeleka sasa uko majuu.
The real concerns with data. We keep on giving data, we feed data today, it goes to the national and does not come back to us. Mara it is close somewhere, we cannot get it, or it cannot be able to help us here. Then why do we gather it here? They should then bring officers that are meant to pick data for the nationals only. Then we are not bothered. But if you use our officers here, then you give them tools that they feed this data and then they do not see it again. We do not know what it is used for then. So it is very important for us to come up with a tool that will recognize that Homa Bay County participated in developing the tool, and it is owned by the participant and the players. And therefore the implementers of our policies will own it. Definitely the buy-ins, the support that will come from the national government, from the county government, from the partners and every other stakeholder becomes very key for us. And I would be so proud if we use your technical team and our technical teams in the proper training of it, so that when we are moving somewhere, we are singing the same tune.
We can have integrated visualization from monitoring of growth to physical assessments, to things to do with nutrition, disability, to things to do with cognitive functions. All this will have a one-stop shop.
Huyu ni mtoto wa 5 naendanga kliniki Marindi. Naona serikali inaendelea kuleta huduma nyingi ambazo zinashirikiana na wafanyikazi wa health, alafu inawashika ndio wanaweza kusaidia wanawake wakijifungua vyema.
But their priorities, a lot of the counties, but now I speak for the 3 counties we have closely engaged with, we find that the mother and the child, maternal and child health and development are their top priority areas that they want to support.
Okay, in Marindi, our average birth delivery number is 50, but currently we are doing 60. Yes. So most of the cases that we refer are obstructed labors and newborn care services that we do not offer here in Marindi. When we are referring a patient, we don't charge anything. We don't charge. We just call and the ambulance come to pick the patient. We are registering such good numbers. As a facility, we have maternity open days where we talk with these antenatal mothers. We give them health talks during antenatal care. We take them tour around the hospital, the maternity, they see the services we are offering. Also we have a hot shower, we give them after delivery. We have some beverages, we give them after delivery, and baby pack also. Yes. We also have our community health promoters are also doing good work, referring as mothers in good time.
HP wetu anaitwa nani yule? Florence Onyango. Anakujanga, anatuvisit, alafu anatuambia vile tunakula chakula local foods kama mboga, machungwa, ambayo vitu ambayo inaongeza damu na kuenda kliniki.
The rule of thumb is no mother should die for any reason. And maternal mortality rate is death related to giving birth. And it's sad that we've had very high mortality rate, but the hope is that there's been recently a lot of effort in Homa Bay especially to bring down that high mortality rate.
We've concentrated on the mother, and we're happy that Homa Bay is celebrating its 85th day with no maternal mortality. But we told them there's the child, there's that born one. Can we try to strike a balance so that even that space is considered and is reviewed?
So their priorities is to save the mom, save the mother, save the baby, but not to stop there, to make sure that baby thrives, but not even to stop there, to make sure that they achieve what they're supposed to achieve. It's good to thrive, but you have to get to your highest potential. We believe that the platform will still have a GIS kind of component, which can even go down. We've opened it out to be able to visualize a child at all different points, from the county level where we believe decisions are made, and those will be summaries or many children at the South County level, but at the household level, it can be able to go down to locate this child who has malnutrition, who has severe malnutrition, and is being flagged up and inform the service providers at the health facility. Also to inform the CHP to go down and address that child, to bring them out and present them at the health facility for interventions. This is something that is going to be lifelong. It's not just a project. It's something that's coming to improve systems, improve service delivery, and improve the future of the child in Kenya.
It will also help us navigate and see how to inform programs. How do we, all of us together, because the child is one, how can our immunization coverage, how can we target the ECD classes, how can we partner with the Ministry of Education, the social department, issues to do with disability, all together where everybody can access the data.
We do a lot of work in the schools as well when you're looking after the children. For example, we do deworming in the schools, but how we do it is we give the schools batches of albendazole and the other drugs that they use for deworming, and then of course the school administers, they've been trained to do that. But at the end of the day or the season, we would like to see that information. How many have been given albendazole? How many are yet to be given? Were the drugs even enough? Those records, you know. But because of that lack of information crossing back to us, so it's a challenge.
Because there is no system, existing system that give us the transition from the health facility, or those people from 0 to 3, the baby cadres. We only meet them in the school, and therefore from the entry, from the register that we get once during their transition from home, that is what we use. So we don't know how many maybe have died in the course, or how many are still at home and they are supposed to be in the school. It is only that we are only at the receptive end. The people that we get is the people that we consider to be the first enrollment in PP1. But if you have a system that can show us the children that have come from the health facility, then transiting, their age is now there to transit to the PP1, we would be very comfortable, and it will inform our transition rate.
In Ngere, age to 5, those ones are I pupils. PP1, PP2, we have a population of 100. These children are coming from different homes. So I think the data will help us to maintain them in school. Maintaining them in school means they are supposed to be comfortable in school so that they learn. If they are really maintained in school, the way I'm telling you that the health program is there, the school, the classes are good, food, the feeding program is there. Most of the parents will love their children to be in such an environment. So most of the parents will bring their children to school, so the number can even go up.
Many times, we cannot even know whether our teachers are at the teaching points or centers. But now I believe that this system is going to tell us where the teacher is. It will also tell us where the supervisor is, because we get reports, some of them are just written in the house. But with this one, it means that the teacher, I believe, my intention, I believe that the teacher will only give us the report when he's in the school. When he's in the school teaching, that is when he will give us the report. I think the structure will be in such a way that it will not allow any report from home. It will allow the report when we use even we call the GIS. It will allow us, it will allow the teacher to give the report only when the teacher is in the school. And that would give us accurate information that the teacher has been teaching, the supervisor is doing the supervision, the subcon director is carrying out his work without any problem, and then we get the right information. So it will enhance kind of quality assessment in terms of our children. Once there is quality assessment going on, then the outcome will be positive. There will be positive response from the targeted group, whether the early years child.
Well, in terms of the disability identification, there is a challenge first because we don't have a tracking tool that is usually used in terms of tracking the person with disability or children with disability who are attending school between the age of 0 to 5. Then persons with disability and all children with disability attending the regular schools is a challenge because we don't have special schools within Homa Bay County. And now because we are going out of the regulars, the inclusivity, we are talking about children being included in a regular school. So this platform is going to help us to capture the number of children with disability, the number of the assistance needed for these children with disability, and also in terms of the teaching learning resources that are supposed to be used within the schools is going to help us, because if we don't have this data, we cannot know the need and the necessity of these children with disability.
I am foreseeing where the platform on data can also support county government in decision making, because one, we have to understand the number of children in the county that need support and their interventions that they also require. But then, just as one of the speakers said earlier, if you do not support children, then we might end up losing a number. And therefore, that is why we come in as non-state actors to collaborate with the county government to ensure that even in the reporting system, how then is the data informing part of the resource mobilization, how is the data informing part of the interventions, and therefore a survival for our children from 0 to 5 years old.
This is something we are testing or developing on just 3 counties. But you and me are aware that we have 47 counties across Kenya. And in all those 47 counties, we have children. At the end of this specific project, the 4 years that Conrad has funded, we believe that we should have established that platform for each of the 3 counties. So each county, Homa Bay, will have a well-established platform that does the things I've described, informs reporting, but also monitoring, as well as service delivery, decision making, and the whole loop round. And the same to Isiolo and Nairobi. And so at that point, we'll have something that can be scaled to the other counties, because we only have a few children in these 3 counties, and the other 44 counties will still need such a thing.